Welcome to the SkillsForMed webinars. This week's topic, and that is navigating difficult conversations with the patient and family. I think it's a very, very important topic to discuss. None of us actually learn communication or taught the proper way of communication in either the medical colleges or the nursing colleges. And we all learn the ropes as we keep practicing by making mistakes. But there are a structured way of doing things, and that is what I want to present today. And so let's get into the topic without any further delay. I'm going to cover what are difficult conversations first. And then we will get into in detail about the methodology to break bad news to the patients or the family. We are every now and then called to do this, isn't it? We need, though we want everybody to be happy, there are many patients who deteriorate. There are many patients who actually die in our hospitals, and it becomes our responsibility to break this bad news to the patient's family. And what is the approach you should take is what we will deal mainly in this webinar. But I'll also showcase dealing with angry and difficult patients and end-of-life conversations with patients also. So that'll be after we talk about breaking bad news. Now, what are difficult conversations? Why are we talking about difficult conversations in a healthcare setting? So these are typically involving discussing sensitive topics with patients and the families that may evoke very strong emotions. It's not just bad news. There are many other things we may tell the patient, or the patient themselves may perceive certain things differently. So we are forced to have difficult conversations with them. So, no, this is very important. For example, even last week, I had a patient who was having a very difficult gallbladder. The patient came almost 3 months with the infection. So we had to do a surgery where we removed all the infection. There was a liver abscess adjacent to it. We cleaned it up. And in spite of me telling that I may not able to be remove the whole gallbladder. Now we do what is known as a subtotal cholecystectomy. That is the norm now because you don't want to injure the bile duct and all that. So in spite of that, though I had removed almost the whole gallbladder, leaving just as probably 2 centimeter or 3 centimeter remnant, the family was very unhappy, and I needed to have a very difficult conversation on my reasons why I should do this. So in these type of conversations, you cannot become defensive, you cannot react, but listen to the patients and families' concerns and counsel them properly. So this art it's not actually an art because people think that conversation is an art, and some people have the gift of doing this. Yes, of course, some of them have the gift of the gab, as they call it, but every one of us can actually develop the skill of how we could deal with these sort of different strong emotions and difficult conversations. So, for example, these are some examples of difficult conversations, delivering bad news, discussing a poor prognosis of a disease with the patient, navigating end-of-life care or when a patient is dead, and addressing concerns about the quality of care. People have become very, aware of the quality of care that has to be provided. They expect hospitals because they look like five-star, hotels now to provide the same level of five-star comfort when they come to the hospitals. So that is only the covering, the cream on the pudding. But actually, what we are talking about quality is patient safety, avoiding errors. And when such errors happen, then we need to have difficult conversation with the patients. Now, why are they difficult? They're difficult because each person or each human is totally different and each has got a different emotional complexity. So one patient may take the same news in a very calm manner. Another patient or family can take it in a totally different manner and be very reactive about the whole thing. So that's one. The second is cultural sensitivity. This is on our part. So there are many times that we really do not look into the cultural, what is the values that the particular family or patient has got, and what is their beliefs. We don't have the time, we say. Now we say we are so busy with, all the dealing with emergencies and all that. I think we don't really look at the patient's beliefs and values. So this is the lack of cultural sensitivity is also one reason why it makes conversations difficult. Then we have ethical dilemmas. We want, no, we have to be transparent and open and tell all the facts to the patient and relatives. But the relatives may come and say, no, no, don't tell this to the patient. And do you listen to the family's wishes, or is it your professional responsibility to reveal and be transparent? So these ethical dilemmas also make it difficult for us to have these conversations. And communication barriers. So the communication barriers, the main barrier we face, or I would say, is when you are telling something very grave or something which the patient and relatives do not expect. Usually because the first reaction is denial. That's one of the known responses to grief. So when they are in denial, whatever you say actually does not get into them. They don't actually they understand, but they don't internalize it. So this mental barrier is what is very, very important more than language barriers or anything like that. You may be talking the same language. No, they may fully understand what you say, so after explaining of 10, 15 minutes about how serious the patient is, and almost, the patient had a near arrest in the operating theater, and we're going to shift the patient to the ICU, and the patient is on 400 drops, fully ventilated. And all that you explain to the patient and relatives, all they would say is, "Oh, I hope he'll be all right, isn't it?" Because they're not actually internalized it. So you have to identify this communication barrier, and this lack of understanding also makes it these conversations difficult. So these are some of the factors. I cannot not keep telling about everything, but I feel these are some of the major reasons why these conversations are so difficult. So in today, what we're going to talk about is breaking bad news, mainly. My majority of my talk will deal with that. And we also look at how to handle an angry or difficult patient or family. This is becoming more of a norm than exceptions in hospital nowadays. I mean, we've all been looking at the criminal act which has been happening in Calcutta, but that is actually an isolated incident of a criminal activity. But a very day-to-day thing which every hospital faces is the emotional outbursts the patients and relatives have because of um, unrealistic expectations. Uh, Mainly because we have painted and sold ourselves as if we would be able to cure everything and anything in the world. So that angry and difficult patients are becoming more and more in our hospitals, and it's very important to actually know how to go about this, or no, or at least have a framework which we can teach our juniors and other peers in our organization how to deal with such patients. The third is which we have been dealing all the time is the end of life care. Taking a patient and the family through the process of dying is something which is very, very has to be done very sensitively. And I would say that many of my patients who are very loyal to me and who bring a lot of other relatives are ones who actually one of the relatives I have actually taken them through death. So many times when you start the practice, especially in surgery, I used to be frightened by my seniors saying, "Pari, make sure you don't have a death in the first 5 years." And if you operate enough number of patients and they're willing to take patients who are really sick, you cannot avoid this. But even in those situations, if you take the patients sensitively through that phase, then actually they appreciate you for that. So these are three things which we are going to discuss today. So in that, the first thing, as I said, is breaking bad news. Now, None of us want to hear bad news, isn't it? I mean, we are, as humans, we try to avoid hearing any bad news. But as you live life, it is part and parcel of everybody's life. That every now and then you have to listen to bad news. It may be because you know which affect you more because it is people are near and dear to you, or it may be somebody who's distantly related. And in the hospital, we have developed this mechanism of blocking our emotions, isn't it? We don't actually weep for each and every patient and becomes bad or anything. We professionally we have developed that ability, but at the same time, showing the sensitivity to the patients is important. So patients in the family also are humans, and they don't want to hear bad news. So we've got to understand that. But no, delivering bad news is inevitable, and it is challenging both for the giver of the information and the receiver of the information. So it's not a pleasant experience for both, but we've got to do it. So, what is the bad news? Bad news is any information that changes the patient's view of the future in a negative way. I really like this definition because bad news can be told, defined in many ways, but this is a very generic definition which can apply to any bad news you give to anyone. So that information which changes the view of the future. Now that we are always expecting an optimistic view, future. A positive outcome is what as humans we expect. But this particular piece of information will change our view of the future in a very negative way, and that the patients will not be able to cope, and we don't have the ability to deliver this also properly many times. So that is no bad news. So when you're talking about bad news, certain general principles you have to follow. So don't go straight away and blurt out what the bad news is. You've got to soften the blow by giving a warning, saying, "Sorry, I know, I have to tell you something which may not be very pleasant. Can I start telling you that?" And very very important to be frank. So many times, cancer and death are two words which we are also afraid to talk about, and the patients also do not want to hear about. So all the literature on bad news or delivering bad news will tell you that you have to deliberately, especially talking to the patient, you need to use these two terms, cancer and death. So when you mention that, no, then patients actually understand. But if you try not to do that, then in the end, they may not have a full understanding of what you're really talking about. So you need to be frank and at the same time very compassionate in the way you talk. And before you start, it is very important to understand what the patient or the family already know about the condition. So it is another good way to start the conversation. You introduce yourself and say, "No, I've been talking to you for the last few days. What do you understand about your father's condition or mother's condition, or about your condition? Can you tell me what you understand?" So that gives us a basis or a foundation from where we can start building what we want to say. And you need to be patient. No, you can't be efficient with people. No, you can be efficient with anything else, but with people you cannot be efficient. So you've got to give the time. You cannot say, "No, I have a surgery, or I have an appointment in another 5 minutes, so I got to tell you this." So it doesn't work that way. So you got to give the patient time to understand and to accept the information. Many times, when they when they break down and they start crying, we have to simply sit, maybe hold the hand and just be silent. So that's very, very important. So a trusting relationship between the nurse and patient is extremely important for effective communication on all stages of, especially the palliative care. Okay. So patient's family is a totally different ball game, and because each family is a different unit and they react in a different way, and it's our duty to provide emotional care and support to the family. And we have to allow the family member to process the end of life, and sometimes eventual death of a loved one by uninterrupted communication. Communication is the main thing. So, and nurses, I think, play a very, very important role because as doctors, we will sit and have an interview, maybe 15 minutes, maximum half an hour, if it's a multidisciplinary meeting, and then we leave. And the rest of the time, they're under the care of the nurses, and it is the nurses' responsibility to keep communicating with them constantly, tell each and every change which happens, and keep them updated. But we have to be mindful of the emotions or they go through. So, when dealing with an unconscious patient who is actually very sick and near death is very, very difficult because you got to only communicate with the family and the caregivers. So they are also totally at a loss because many of the time, it's not our in our culture to write a will or anything like that about whether you want ICU care, whether to be ventilated. These sort of things are not done. So it becomes a responsibility of the patient's relatives to take those decisions. And how much you may try and explain the situation is for a non-medical person is very difficult to deal with this. So it's this is one of the most difficult conversations you can have with the family of a patient who is unconscious, and so you have to tread very carefully. Now, what is the patient's expectation? So this is a study which showed that many patients believe that they should receive the initial news directly from the healthcare team rather than the family members. This is something which is new to me. So many times, I would tell my patients, do you want me to directly tell the patient, or you want to, as a family, discuss about what I have told you? But this research, which was done, actually changed my view about the whole thing because they did a study of various age groups, young patients, middle-aged patients, and older and adult patients. Irrespective of the age, especially they did it, this is an oncology journal which came about the end of life care. All cancer patients had the same communication preferences. That is, they wanted to be the first person to hear the news from the healthcare worker, that is a doctor or whatever, and they whom they wanted to be along with them is also their preference. They wanted to be in charge of that. So this is something to keep in mind. So just don't keep the patient in dark and then talk to the relatives. So this research shows that the patients expect that you tell them first. A very important point to remember. Now, I'm going to go to the next section of my talk about breaking bad news using the spikes model. Now, many of you might have heard this model, and many of you may be actually using it, but I thought it's a good way, to just structure your approach in breaking bad news. It has helped us quite a lot, and there's also in emergency when I was heading it for almost 10 years. This is something which I used to teach the juniors. So the spikes model, each word is an acronym, SPIKES. Each stands for a word, and that it reminds us what we have to do. So this can inspire confidence and effective disclosure of bad news. It has been shown in many studies, and people or healthcare workers who become comfortable and well versed in this delivery actually are much, much better than somebody who's just doing it without any structure. So it really helps to learn this model of breaking bad news. The more comfortable you are with breaking bad news, the more likely that the outcome of the conversation will be better, and the patients and the family also feel that it has been done in a very professional and structured way. Okay, the components are, as I said, each letter stands for one word. S stands for setting. P stands for perception. I for invitation or information. K, knowledge. E, empathy. And S, summarize and strategize. Okay, so that is the spikes model. So we will now get into each one of them one by one. So the first step of the spikes protocol is setting up the interview. So the S stands for setting. So what do you do to set up the interview? You need to prepare what you're going to say. The physical space is very important, and the preparing the emotional state of the person who's delivering the bad news. No, those are receiving it. No, also will have to be in a shape of state of mind, but you need to be in a good emotional state if you're going to deliver it in a very effective manner. So that is a setting. So there are three things in this. One is preparing yourself. Second is preparing the environment. And the third is preparing the patient. So we'll look at preparing yourself. So first of all, go through the case sheet, review the information, and then choose your words appropriately. And whatever you're going to say, you need to consider the implications it's going to have on the person who's going to receive the news. And you should also know what is the planned treatment for the patient, the care plan, what is the immediate plan, what is the long-term plan. You should have a thorough knowledge before starting the conversation. You may be nervous, when you're young and starting off is one of the difficult conversations, and therefore you may be feeling nervous. So you have to manage that. And proper body language. I cannot emphasize more. So you need to show that you're attentive. So even though you're maybe sitting in a revolving chair and all that, don't casually sit back like that. No, you got to bend forwards. Lean towards the whoever you're talking to, which will show your earnestness and sincerity. So body language plays this. This is called non-verbal communication. So body language plays a a very large part in while delivering the news. So all this you need to be conscious. So that is preparing yourself. Preparing the environment, shows a quiet space. Definitely do not do it in the corridor. And you should arrange the furniture to encourage better body language. Usually, all the chairs should be on the equal height. So this is not the place to show your no superiority, anything like that. So better arrangement will be sofas and a table, a box of tissues by the side. The counseling area should be very nicely arranged. And it is better you sit in the same level so that their eyes are in level with the persons or a person you're going to talk about. Put your phone on silent and ask everybody else to actually switch off the phones and then start the conversation. So that is preparing the environment. And prepare the patient. Suppose the patient himself is whom you're going to tell the news. You assess the emotional status of the patient first and see if they are ready to listen. Sometimes you have to just operate the patient. There'll be a lot of pain, or even if it's a cancer patient, you're not, they just got admitted and they've gone through all the investigations. They're very uncomfortable. That's not the time to have a conversation with them. So you give them adequate pain relief, make them comfortable, maybe postpone it for a day or two, and then have this conversation. And also respect the preferences. So you can ask, whether you want to me to talk to your family or you want to talk to you and respect their preferences. So that's the setting. S stands for setting. The next letter is P, which stands for perception. So perception is you have to be sensitive to understand the patient's, what is the patient's understanding and perception about the situation. So that is why, I told you, first start off by asking, how much do you know about do you know what is wrong, with your body? And how much do you know about it? Okay. And also you can also assess, you don't need to ask them. From talking to them, you will understand how much actually they want to know. So it may be prudent to give the information, in portions. So we do that many times. Even though we may know it is a very hopeless situation, the first day when we talk to them, we just tell them the seriousness of the condition. No, very serious. No, patient is, heart is not functioning. We got to give the drugs to, keep the heart going. His lungs is not functioning. The kidney is, put out. So we may probably, planning dialysis. So you tell all that. And then the prognosis part of it, maybe, you delay it, depending upon, how sick the patient is. Patient is very sick, then you probably have to, do it in a few, half an hour or 1 hour. So, but assess what they want to know is very important. And again, I mentioned this about denial because most of the time, they don't want to accept. And, so it's not very wise to keep on pressing and saying, no, you got to believe what I'm going to say. So if they're not actually, that there is denial, and they're not actually, no, it's not getting into them, it's better to leave it at that. Because on their part, this is the process by which they're going to handle grief. So the first part is denial. So you got to allow them to go through that phase rather than shattering that. Okay, so this coping mechanism is very important to understand. And just give the information that is appropriate for the patient. So many times, still the patients want the reassurance from you. Even though you know that it is a hopeless situation, there's nothing wrong in reassuring the patient that we are doing our best and we will be there for them and do whatever what you have in your capacity to make them feel better. So you've got to put it in a language that it is not falsely raising hope, but at the same time reassure them that everything is being done and that you are with them in this journey. So very important to do that. And the facts should be sufficient for them to provide informed consent for further testing or treatment. So you don't need to go and tell, especially pediatrics or adolescents. Now you need to be careful what you're going to talk to them also. So that's perception. You look at the patient's and family's perception and then adjust your conversation accordingly. So S is setting, P is perception and sensitizing yourself to the what the patients want. So I is invitation and information. So you need to ask permission to share the current news. So you can tell them, do you think you're ready for you to have the conversation? Or can I go ahead and tell you about what is happening, to you or to your relative? So that permission is very important. And you can also ask whether they want, no, just a brief about what is going to happen, or they want a whole detailed breakup about what is going to happen. So many of them, maybe not in a situation to listen, so they will say, no, no, just tell me the essential things, and I'll come and ask you if I want more information later. So you've got to ask that, so invitation and asking them what they want to know is very important. And so the amount of information, it has to be tailored to each and every patient or family. So that is what this I is all about. So the setting is preparing yourself, preparing the environment, and preparing the patient. P is perception. No, be sensitive to identify the perception of the patient and the family to know whether they're ready or not. And I is invitation. That is whether you are invited by them to give the news and how much of information you're going to give. So that is SPI. K is knowledge. Okay. So this is where you are transferring the knowledge of the diagnosis to the patient or relatives where it becomes their knowledge. So as I said, first is, sort of telling them that what I'm going to tell may not be very something which you are expecting, or something which be contrary to what you expect, or it may not be very pleasant. So this warning is very, very important. It allows them to brace for what you're going to say rather than straight away telling what is the bad news. And you should understand what is the level of patient's understanding and how much they want to disclose to them or the family. So as I told again, this ethical thing is there. So the family would have told that no, don't tell the diagnosis of cancer to the patient. You have to be sensitive to that. So you'll only say for example, patient has got a carcinoma colon which is totally obstructing. So you only talk about the blockage in the intestine and how you're going to clear, but you don't actually tell the diagnosis of cancer. Okay, so that's something which you have to dynamically understand how much they want to know and how much should be disclosed. So be honest, tell it in small segments. Don't use medical terminology to large extent. You need to practice to break down the information into simple, easy to understand words and tell them that. So after giving the knowledge or information, you got to stop and ask them, have you understood what I have said? You can also ask them to repeat back or teach back, it's called, to what they have heard and understood. So that's very important to know, because many times what you say may be misunderstood the patient, and then the whole conversation you will think is going in one direction actually is going in the opposite direction. So that is knowledge. S is setting, P is perception, I is invitation, information, and K is delivery of the knowledge to the patient. So E is empathy. I think this is there all the time, though it doesn't come serially like that. Right from the time you start, no, you need to have the empathy. So you need to acknowledge the patient's and family's emotions during the discussion. So empathy says it is, the art of putting yourself in other people's shoes. I think it's not always very difficult. No, whatever you may say, it's very difficult to put yourself in other people's shoes 100%. But at least try to, do that and don't judge. And because one person will be totally breaking down and crying, the other person may look actually they're not bothered. But these are all different coping mechanisms each person has. So you need to have that empathy and take them in the appropriate manner. So that is the E. S, setting. P, perception. I, invitation, information. K is knowledge, and E is empathy. And the last is summarize and strategize. Both are important. So the end of the conversation, you need to summarize. And what is the strategy after that? What is the treatment strategy? What are the treatment options and management care plan? And in our country, where most people are paying out of the pocket, it may be essential to talk to the family, or if the patient asks about the financial implications of what is the treatment you're going to do and how long it's going to take and all that. So, in summarizing, what obviously you will summarize the key points. Okay, this is what you summarize the key points, the diagnosis, the reason for which you have the diagnosis, what is the immediate steps, what are the long-term steps, what is the prognosis, all that you summarize. Ask them if there are any further questions, and you can also offer saying that if there are any other person whom you want to talk to, close relatives, it is I can talk to them. But sometimes this people may take advantage of it, and every counseling session a different person will come. So if you find that happening, then insist that there should be one point of contact who's constant, because then you will spend most of the time counseling different members of the family, especially if the person has got a relative living abroad, then that becomes even more complex. So again, summarize the follow-up arrangements, and then you got to leave the room. So, or sometimes, I get up and open the door and assure the, patients and relatives out, and then I close the door and come out. So, it's all, showing that respectfulness and earnestness to the, patients and the relatives. So that's about spikes. Okay. So this is the setting, the physical setting, the preparation of yourself and the preparation of the family. P is perception. I think this is the most important. Perception is being sensitive to what the patient wants and all the relatives wants. And I is the invitation and how much information they need. K is the knowledge you give to the patient and the relatives. E is handling the emotions, empathy and emotions, and S is summarizing and strategizing. So SPICE is a good framework. So there are no such frameworks for the difficult patient, but I sat down and developed, our team sat down and developed a few frameworks which I want to share with you. And so who's a difficult patient? A difficult patient who presents challenges to the healthcare providers during the care. Okay, unreasonable challenges, you can say. Okay, so but from the patient point of view, it is entirely reasonable. So a non-compliant patient, like went on rounds yesterday to see the venturi mask hung on the humidifier in a patient who was in ARDS and who was almost on the verge of being put on the ventilator. So this is a non-compliant patient and a non-compliant relative. The reason given was that the nose was aching. Okay. So you need to have such difficult patients, and you need to have conversations with them. You can't lose your temper. You can't shout at them, but make them understand in a clear way that what is important for them. So angry or hostile patients. This angry, hostile patients, as I said, has become more of a norm in all hospitals. A demanding patient. No, this is another patient. No, who wants to get everything. No, on time. No, and see the most senior most doctor, and doesn't want to get stand in queue in the pharmacy or billing. So the demanding patient, and anxious and tearful patients who are just break down and you don't know what to do, and also patients who are confused and disoriented also are difficult patients, though you'll deal with them in a different manner. So can we have a framework like spikes for these people? So this is what we came about. So these difficult patients are, your tendency is to react, isn't it? When somebody is shouting at you, you want to shout back at them. So react. So using this word react, there is a framework which we can develop. So REACTS is the acronym. Okay. So React, R stands for recognize the signs of escalation. What do you mean? Signs of escalation is that a patient who's been now talking normally to you suddenly talks in a louder voice. They are standing up, and no, the body language has changed. So these are all subtle signs that they are going to become aggressive. So you have to recognize the signs of escalation. That stands for R. E is ensure your safety first. Very, very important. Ensure your safety first. So you need to make sure that you're in a place where you probably, if you're sitting in a consultation room, you go to the entrance near the door and then talk to the patient. You make sure that there is a table or furniture in between you and the patient. Make sure there are not loose objects around. So when you're counseling, you've got to make sure that you set up the room also, for like this. So because they may just, become angry and throw things at you. So ensure safety is important. So RE, A is applying de-escalation techniques. So de-escalation techniques, again, we spoke about conversation, communication. Again, the same thing, body language, non-verbal. Don't look away from them. No, look into them, but don't look into the eyes directly. That will put them off. So look into the region of the face, but don't look away from them. Talk in a very calm voice. Whatever they may lose the temper, you should not react and start shouting at them. So you need to talk in a calm voice. So there are several de-escalation techniques you can talk about, but this is a separate talk by itself. So I'm not going to go too much in detail. Just giving you the framework. C is calmly engage and try to see whether you can diffuse the situation. The more senior you are, more bald and more gray hair you have, the more the ability to diffuse the situation. So if you're young and you're not able to diffuse the situation, call for help. Okay? So turn to support systems. So it can be your seniors, it can be the security, it can be the middle management, a little bit more senior person who can diffuse the situation. You have to turn to support systems. And S is don't disown the patient because they are difficult. Okay, you need to, as a professional, stay involved, keep following up, and make sure that they understand why it was difficult for them, and give the a little bit of tender, loving care so that they are feel good about it. So ultimately, if you take a difficult patient through this very agitated phase, they actually become very loyal to you. So this is a framework. So as I said, this is a whole a session by itself, how to deal with difficult patients. But I'm just giving you the framework. Reacts. The R is to recognize the signs of escalation. E is to ensure safety, your safety. A is apply de-escalation techniques. You have to engage with them calmly and diffuse the situation. If you think you're not up to it, turn to support systems. And S is staying involved. Don't give up on that patient. So that is difficult patient. So the next framework we want to talk about is end of life care, or the or deceased patient. So it involves carrying, once the dead patients, it involves carrying of the dead body, but end of life care can be quite prolonged. The patient may be still alive. So you need to take them through this phase, and how do you do it? So here is another framework. So it is called support. Okay. So this is just like spikes. We have this another framework called support. So again, as a sensitively initiate the conversation. So when you talk about end of life care or death to a family, you got to be very sensitive and initiate the conversation in a very sensitive manner. So use to understand the patient's values and preferences. I talked about in the beginning also. So the more you have been in contact with the relatives, you will understand this. But very important to understand the patient's values and preferences. U stands for understanding. P is then provide the prognosis or the news of what happened. No, the death has happened. Then you do that. So the first two are important. No, you got to start the conversation, establish a rapport, understand what the patient's or the family's values and preferences are, and then you provide the prognosis or the news. And then in the end of life care, you know mostly it's supportive, then present the options for treatment or support. So that is the second P. The first P is providing the news or the prognosis, and the second P is presenting options for treatment. O stands for offering involvement to the family. So whatever the family wants or what family preferences are, you have to ask them and give them whatever is needed. So that is offer support or involvement to the family or of the family. Then you need to sit and have a discussion, especially for people who death is imminent. You got to review the end of life preferences. So not many patients or your human beings will be able to talk to us. It is not our culture, whereas the Western culture is totally different. So they'll be able to talk very calmly about, what coffin they want and what type of, burial they need and all that. But you can talk to the family to find out what these preferences are. So review the end of life preferences, and very important, have somebody, maybe a psychologist or somebody who's very supportive, or you can yourself do it, tend to the emotional reactions. That is quite natural when you start, having conversations at the end of life. So that is the framework support for end of life care. We looked at spikes in detail, but these two, I just mentioned so that you can sort of build up on that. And that brings us to the summary of this talk. So difficult conversations, we saw what are difficult conversations, why is it difficult, and then we looked in detail about breaking bad news and how to use the spikes model. Then I introduced you to the conversations we have with angry and difficult patients, and who is a difficult patient and how to use the reacts framework, and end of life conversation, what is end of life care, and how to use the support framework. Thank you so much for your patient listening.